Good afternoon and welcome to one of the dynamic components of the new cardiovascular imaging. This is a feature that's going to be persistently seen in many of the articles. It's my pleasure today to introduce Dr. Robert Moss and Dr. John Webb from the University of British Columbia and Dr. Bill Stewart from the Cleveland Clinic Foundation. We have three pioneers which are spanning the field of interventional percutaneous valve implantation and echocardiography, and their topic is going to be a discussion of the role of echocardiography in percutaneous valve implantation. My name is Dr. Chandrasekhar. I'm one of the associate editors of the JACC Cardiovascular Imaging. Welcome. Dr. Moss, tell us about your paper, which we found very exciting, and what did you show?
Well, in our paper we set out to really determine what the role of echocardiography was in percutaneous heart valve implantation. So primarily we're interested in how it assists us in patient selection and how we can evaluate outcomes with this technique, with echocardiography, but perhaps most importantly we looked at the role of echocardiography, particularly transesophageal echocardiography, in assisting the interventionalist to deploy the device. I think our paper sort of showcases the collaborative role between the interventionalists and the echocardiographers at our institution in pushing forward this new technology.
Dr. Webb, what did you find and why is it such an exciting paper?
Well, you know, I think initially with percutaneous aortic valve implantation and transapical for that matter, there have been many issues in terms of implanting valves, including appropriate sizing, appropriate positioning, and management of complications, as well as paravalvular insufficiency. And all of these things, I think, are tremendously benefited by close cooperation with echo. And we routinely do, of course, transthoracic echoes for screening purposes and measurement purposes before the procedure. We routinely do transesophageal echo during the procedure, which we found very, very helpful. Clearly a learning curve there, but very, very helpful, I think, in terms of improving our results.
Dr. Stewart, you wrote an editorial for the upcoming issue. What did you find exciting about the paper, and can you just take us through the role of echocardiography before, during, and after a percutaneous valve implantation procedure?
Well, the Vancouver group clearly has a great experience with taking care of patients with percutaneous valve replacement, and they've learned, as is clear from their paper, that it's very useful in all of those phases. And in particular, it's useful to design the procedure and as well to assess its success. And during the procedure, the process of placing the valve in exactly the right place, exactly with the annulus of the patient in the mid or to upper portion of the crimped valve, for example, and then immediately on expansion of the valve to look for aortic regurgitation and look for the proper placement of the valve. Those are very important monitoring things that are very similar to other procedural echocardiograms that have been used elsewhere.
You had a number of patients where after the procedure, initial part of the procedure, echo kind of showed you something which made you go back and dilate. Would you want to expand on that and tell us the role of using TE to assess complications and change your strategy?
You know, very early in the experience, the incidence of moderate and severe paravalvular leaks was very, very high in the early transvenous experience. And I think in our experience, the incidence of severe paravalvular leaks has been really none at the time of discharge from the hospital. And this really relates, I think, to better understanding of the positioning of the prosthesis within the aortic annulus. And we've quite significantly changed our strategy based on our early echocardiographic imaging to deploy the valve a little bit lower within the left ventricular outflow tract to get good sealing of the cuff of the device against the annulus and reduce paravalvular leaks. And also, the advantage to esophageal echo is that we can immediately see after deployment whether there is under-expansion of the valve and a paravalvular leak present, and not infrequently we'll go on and redilate the valve and get a more symmetrical circular expansion, better sealing. So I think that in terms of positioning, there's been tremendous value, and that has reduced paravalvular leaks because of accurate positioning, and also in terms of the understanding of redilating the valve to get good sealing.
Dr. Stewart, with the upcoming 3D TE, do you think our ability to diagnose and treat becomes better during this procedure?
Yes, I think that's true. I think that the 3D echo, particularly on the transesophageal probe, has, in the early experience, offered some greater ability to see in 3 dimensions, obviously, and to see the medial lateral and the superior inferior aspects of that, to place the crimped valve in the right place, to see exactly where it is, to be able to see in 3 dimensions is of great help. And I think that will be true across other procedures which are catheter procedures as well, even more so. The percutaneous aortic valve replacement, in a way, is an easy procedure because there's kind of only one place it can go. But clearly, 3D echo is going to be very useful in a wide range of procedures, closure of paraprosthetic leaks and mitral repairs for mitral regurgitation. All of those, I think, 3D echo will have a great role.
Dr. Moss, how long does it take for an echocardiographer to get ready, or can an average echocardiographer pick up everything that we need?
I think we're advantaged to a certain extent in Vancouver in that we've been attempting to sort of develop a program that has as one of its foci concentration on procedural echocardiography, and we use that not just in the context of the cath lab but also in the EP lab. But I would say there's certainly a learning curve associated with learning this technique. It does require some practice, and in particular just the visualisation or the precise visualisation of the position of the stent is really that's where the buck stops, as it were, and that's the critical point that requires a little bit of a learning curve.
We have 30 seconds. Any last thoughts?
One thing I would wonder from John is, how about the balance between the fluoroscopic control and echo control? You obviously want to use both.
People often ask this, and I think that the key here is that you want as much control as you can get. And ideally you have both angiographic, fluoroscopic, and echo control. And each patient's different. In one patient, one is worth more than another, depending on calcification or lack of it within the valve. Mm-hmm. So we like to have all of these modalities available.
Any last thoughts, Dr. Stewart?
I think that's a very good point. I think that we can't throw out either one, and I think interventionalists tend to be focused more on fluoroscopy because that's what they're used to. And we learned in the operating room with valve repair long ago that we needed to learn a common vocabulary between the surgeon in that case, and in this case now the interventionalist, and the imager, so that development of cooperation and working as a team is very important.
What do you think, Dr. Moss?
I agree. I'd just like to add my agreement, my sentiments to what's already been said. I think the two techniques are very complementary, and in some people the fluoroscopy is more important, but in most the echo is an essential element in deployment of the device.
So if I hear the experts, the future is very near, where we can image perfectly and you can place the valve perfectly. Thank you, gentlemen. That was a very useful discussion.